So parietal lobe is a sensory lobe. The most important part of parietal lobe is to localize the stimuli. Now, whenever you localize the stimuli, there are two things. One is sharp versus dull. So we have to understand the test of proprioception. What is proprioception? Proprioception, agresthesia and agripresthesia. Prognosis, astrognosis. Agnosia, unawareness of illness, denial of future. Non-dominant hemisphere. Apyrexia, example like dressing apyrexia, idiometer apyrexia, construction apyrexia. These are something which defies of the parietal lobe testing. So when you touch, you feel some people have very sharp pain, some people have dull pain. What is the perceptions? Means when you touch, they can feel or they cannot feel, right? You can understand the field of defect. Right? You can understand how the visual you can see field of defect in the eyes. So this speaks about the field of defect. In many times in brain stroke, brain damages, we use the field of vision test, right? You cannot see 360 degrees. Can you see 360 degrees? No. You lose various sight. So this example speaks of amonomanious hemianophilia. You can see. Can you hear me? Yes, sir.
Yes, sir.
Yes, sir.
Yes, sir. Thank you. The visual pathway showing the visual field defects are related to localization of the lesions. So now you can understand there are various lesions inside the brain. The main part is the occipital. So in occipital lobe, if there is a lesion, this pathway speaks about the different parts of the lesion, where you can see left, right, how much you can see. In the right is total darkness, in the left, this much area you can see, the right, this much area you can see. Quarterly you can see, quarterly you cannot see. So more or less this area speaks about homonymous heminopia. Heminopia. So this is also one more characteristic in brain stroke with different folks. So you can understand when we speak about different flowers, we can understand various characteristics happening inside them. That's what I say. If you want to learn something, you have to learn the deep of the way. So when we see a patient, we see that lot of defects comes in them. Some can be repaired, some cannot be repaired. You have seen, tomorrow we'll try to put a patient on Facebook whose wife was quarreling with me that he cannot walk. And now you can see with the support of a person, he is walking. He did not walk for 1.5 years. He was on wheelchair. And these people were shouting that he cannot walk. And today, I made him walk yesterday only one, but 10 minutes. Tomorrow you will see that person is climbing staircases. So whatever we think is not always correct. And whatever we may show may not be always correct. Correctness comes only when you realize. So see, remember my one formula. What is my formula? It's $1 billion formula. Whatever you see is not correct. Right? Whatever you see is not correct. Whatever you hear is also not correct. Whatever you read is also not correct. Whatever you understand is also not correct. And whatever you may think is also not correct. So we may relax it to various perspectives that whatever we are thinking, we may think as per our experience, but we may not think as per what we are going to learn. It's just pouring water in the full glass. So when you understand these things, you can understand in the broad perspective And when we see a patient with such type of characteristics of emotion, we understand that the things will change and the things will come. And the corrective medium is called neuroplasticity. It is only the way we can stimulate the brain, and when the neurons fire, they fire. Now we don't have various machines by which we can stimulate them. So we had to classify things as per the complication. So every complication is its own important. For example, occipital lobe is involved with frontal lobe. So you cannot see, you cannot walk. Again, there is a sensory deficit because the sensation are what? Eye, ear, nose, skin, face, mouth, nose, all these are sensory organs. Right? So this is one more way we can understand the theories and understanding of the subject. On the other hand, when we speak, can we understand that recovery can be possible in this, possible in this? Yes, see, now we can understand recovery is very much possible if our selection of the points are correct, if our theory of understanding the disease is correct, the stimulation provided is correct, then I'm sure we're in the right track. The right track is decided by us in the problem. Now to understand the proper way of correction, we understand the proper way of understanding. Right? To understand the proper way of understanding, we see that how you go up and how you go down. Going deep inside is understanding, and when you come under, after coming from the deep, you understand really the sea is beautiful. What you see in the surface is only the water. The beauty lies in the deep. When you start recovering this type of patients, when you start working with critical cases, when you have the knowledge, when you have infrastructure for all these things, you really enjoy. Because you work with those patients which have been medically denied. Yeah, because everywhere there is a limitations, right? So we can do some work up to this level. Others have to do work at the higher level, and thereafter the work has to be done at much higher level, right? So when understood that when we speak about various talks means various type of people who are involved in this type of treatment. So, like gradually the theory is being said, when you understand the pathways, stimulations, nerve pathways, both sensory and motor can be recorded. There's a sensory nerve and the motor nerve, which gives signals to the brain. And these nerve junctions, when they meet together, and there are certain vital points by which the signals can be given directly to the brain, in which the brain can understand. And it can recover to a phase where you can see the recovery of the patient. So recovery becomes very important when you want to in the recovery of the patient. So how the recovery can happen? Recovery can happen by talking to the brain. Brain is its own language of understanding. And in this language of understanding, there are two things which are required. What are the two things which were required? One is the diagnostic technique, one is the recovery technique. Now, if you understand the diagnostic technique, it becomes very easy for you to understand the recovery technique. So once the problem is understood and identified, and you clinically identify, these are the things. Like for example, when we put a patient on ventilator, and we see is gasping. So first is what we do, we go for blood gas test. We call it ABG. In this ABG test, we find immediately what is the carbon dioxide level in the brain, body. Right? We find the carbon dioxide level in the body. The moment we find the carbon dioxide is high, what do we do?
Hyperoxygenation.
Yes? When we find the carbon dioxide is high in the body and the oxygen level is low, so what is the initiative we take?
We give soda bicarbonate and hyperventilation.
We don't give soda bicarbonate at that time. We try to ventilate the patient. Right? Ventilator of the patient has been done, and we put him on what? Fentanyl, metazolam, and what you call nerve blocker. Metazolam we give because it is short acting. We do not know when the patient will resolve. And one neuromuscular block, Sokolin, right? We give it Sokolin in the feeding. Basically, Sokolin is the first which I trust. Fentanyl with Sokolin. Fentanyl is given because it acts fast, supported by metazolam, which is a sedative, and then we give it Sokolin and some other drugs whichever is required for the patient. I'm sorry, today there is no one to help me on mobile. All around me, Sunday. Hello. Hello. A poor fellow has to be on Monday.
Yes, sir, we can hear you, sir.
Yeah, you can hear me, but my phone also will disturb me because there is no one to help me today. On Sunday takes leave. So I am the only person to be on duty. So in between you will have some disturbance. Please don't take care of it.
No problem, sir. Thank you, sir.
Thank you so much, madam, for your kind consideration. And I really appreciate the way you are helping me to take the class. It's a really a very good approach and maturity. It shows your maturity and your willingness to learn. So I'm very happy to see all this. That's what I can say. I'm really very happy to see all your maturity, all of yours, and really will go in the right direction. Maybe those who have done BAMS, those who have done medical graduate degree, they can proceed for PhD in this course. So we are planning to launch PhD courses with different universities. We can enroll with this PhD, those who are BPTs and those who are good qualified. They can directly go for PhD. Nowadays there is an option of direct PhD. So we have decided like Ankit Agwana and all these people who are willing to study further, they can apply in the neurosurgeon. It is for the first time physiotherapists and all these people will apply directly under the neurosurgeon for applying for their PhD. This is a new initiative we have taken. Right? So they have to appear for one exam. This is my extra laboratory. So loss of vision, optic tech and optic radiation. So right optic radiation is left lower visual field in the both eyes. Right temporal lobe is the left upper visual field in both eyes. Stroke in parietal and temporal optic radiation. Homogeneous chain. Hemiphasia, half loss of vision. So we can understand these are the tracks, right? Everything is a track. Track means pathway, the road, right, to reach your destination. So wherever there is a disruption in this road, whenever the road is not functioning, and out of them, I am very happy to inform you, we have nominated Dr. Aicheri for his work in Padma-Shri. I have completed his documentation. We have already submitted with the letter, a copy of the letter to all of us. I'll be happy if you all do that. And also I request all of you to go Google and see Sastry Neurological Hospital and write your positive reviews, not about me, but about the hospital and the recovery of the patient which you have seen. Right? Yes. I request all of you to go to and also request your friends and all to give a good reviews so that we can give a good part of the subject, both not only in teaching but also in the recovery of the patient. We have seen through the videos what we are doing, right? It will help many people to understand what we are doing. So if you go to Google and write your positive reviews, And also, I recommend you to write positive reviews for Dr. Paul. He's a neurosurgeon. He has taken many of our classes, and none of us has written any review for it. Right? So I'll give you the link of Dr. Paul. Right? If you go to, I'll give a link of e-Paul. You please go and what you got. Now, one more thing we are going to do. Those who are admitting the class regularly, we'll collect their numbers and we'll put them in the separate group. Because some people are coming today, some are not coming today, right? So those who are regular students, they will be eligible for many things. Those who are not regular students, let them be happy with that. Right? Now we come to the cranial nerve assessment. So midbrain is associated with optic nerve 2, oculomotor 3, ascending reticular activating symptoms, pupil, pontine pupils only. So when you, these are the cranial nerves, right? So I will be taking a different lecture on the cranial nerve investigation. But I will be taking a different lecture on cranial nerve investigation. How do you understand there is a damage in the brain? So to understand the physical symptoms of damage in the brain, we go with the optic nerve from 1 to 12. Ayo, Ram. So the most important thing when we understand the patient is in coma or brain dead, what do we see? We see the pupils. They are reactive to light or accommodation. So whenever we see, we take a this one, like you found. I'll show you how to see. Right? Torch, right? So this is the torch you have seen, right? So now what we see, we go it like this. So when we go like this, you see reaction of the pupil, right? Pupil is dilating or contracting, right? Like this and like this. So if you move the light, the pupil is contracting, dilating. But when you put the light, it is contracting, right? Am I right? One is contraction, one is dilation. Dilation means like this, and contraction is contract. Okay. So when you see the eye, this one, it explains what the if the pupils are totally contracted, right? They are not dilate with the light. What does it seem? इसको क्या बोलते हैं? If I put the light on the eyes and your people are not dilated, what will we call it?
It's dilated.
No, Baba. There are two things. Either it is dilated chemically or it is brain dead.
Not reacting.
And it's not, if it is not reacting to the light, there are only two things. Either you have put the eye drop, and in ICU, if it is not reacting with ventilator, what do we declare? The patient is what?
Brain
Yeah, the patient is either Barpinski signs is negative, the DTR is negative, and all these things are not responding. What do we understand? Patient is brain dead.
The patient is what, sir?
Brain dead. If the pupil is not reacting to lights, right? And if the patient is in a serious condition, it's in a sick condition. First thing what we see is the pupil dilation. Pupil dilation is seen by the light. So we do it like this. I showed you, we put the light like this. If the pupil is dilating, what do you understand? He is not brain dead. But if it is contracted, you understand is dead. So generally, when we put him on the ventilator, it's like a stage in the OT room. We are giving hourly basis some nerve block, a muscular block. We are giving him those medicines, which makes him what, like a coma patient. It makes him like a coma patient. So how do we know is alive or not? The first examination what we do is we just press on the pain signal near the sternum. This is the sternum. Right? This is the sternum. We put some pain here, like this pain sensation, and we pinch. If the patient is feeling the pain sensation, and we go towards the sternum, we feel that the patient is what? Responding, right? But if the patient is not responding, what do we understand? His stage is very good. Yeah. We call it GCS 3 or 4. It is calculated by E4, P5, M6. So the lower the score, the lower high the sick. The patient is sick. Right? You understood what I said?
Excuse me, sir.
Okay,
Right now, if you press, if one presses the sternum and the patient responds by it means the patient is not in coma. Am I right?
No, wait, no. There are various stages of coma, right? It comes from
Yes,
GCS
sir.
3, 4, 5, 6, 7, 8, 9, 10. So depending on his response, we give a score. If his eyes is opening his eyes, moving here and there, right and left, turning around, obeying the commands, it is called E4, right? So when he's speaking word, I am good, how are you? You are doing nice. We call it what? V2, V3, or V4. V2. And it is responding to the action. Now you do like this. You do like this. Do like this. So we call it M6. So E4, V5, M6. The total score is how much? 50. It is called Glasgow Coma Scale, GCS 50. E4, V5, M6. Right?
Thank you, sir.
So papilledemia is a swelling of the optic disc due to increase of intracranial pressure. Now we understand when there is ICP, there is internal hemorrhagic damage or anything, the intracranial pressure is increasing. That is the brain edema is increasing, right? Pressure inside the brain is increasing. Yeah. So again, this is a very critical condition in which the mortality of the patient is very high, and particularly when it is near the brainstem, right? Anything which is near the brainstem is very bad. You understood? Why anatomy is important? Because you understand that certain patient, even after all these conditions, they survive and they recover. Hello? 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 I'm sorry you are disturbed with my phone call. I'm not attending the class sincerely. I apologize. I sincerely apologize for all this. So carrying is 3, 4, and 4. 3, 4, and 6. Follow my fingers. Extrapolar movements. Elevate the eyelid. Elevator of the pulpit. Diplopia. So all these things are there. Right? We will go in details about in the different lecture. This lecture is not on motor nerve recovery, right? Cranial nerve investigation. This is called what? Cranial nerves. So they are from 1 to 12, right? So just we have gone through a stream that there is a called cranial nerve investigation. By knowing the cranial nerve investigation, we can identify the CNS deficit. What it is called? CNS deficit. So CNS deficit means central nervous system deficit. So cranial nerve investigation is very important to identify the CNS deficit. So once you understand which area of the lobe is uh, involved, it is not always possible that MRI will speak a clear picture, right? So there are two things we often say. So these are what enhanced scope of L2. So we can understand. See, cranial nerve investigation supports us to understand what is NISS score, NIH score, right? So this is a score. Like GCS is a score. NIH is given into a cranial nerve investigation score. It is out of 45. It determines which nerve is active, by which body, which movement of the eye, the movement of the fingers, the movement of the sound. We give marks, right? We are the examiners, right? Examiner of is the condition of the body. Generally, this is done by a neurologist, right? It's a neurological investigation. You should know about this because in discharge meeting, many times these things are written. This nerve is not functioning. Cranial nerve, all are intact, is not functioning. Cranial nerve 1, 2, 4, 6, 8, not intact. Cranial nerve 7, 8, not intact. So by finding out the cranial nerve investigation, what do we understand? We will give him different types of score, right? So all this deeper understanding of scoring will only help you to understand from the discharge summary that where you have to start. So you have a total brain, right? There is a total scaffold, right? The whole body is there with you to start, right? But if you do not know the deeper values and you just start from somewhere, where will you end? You will end somewhere, which is meaningless. So stroke in different form means the cranial nerve investigation, different types of strokes. Now you can understand why you need different types of pain, why you need to advance yourself, because you do not know what kind of patients you are having. Understand? So today you may not understand this in one session. It is not easy for a neurologist to understand in one session. He gradually keeps understanding, right? Even for a neurosurgeon, it is very not easy to understand all these things in one session or one day or one person, right? It's a gradual process. That is why we say we need gradual time and gradual understanding for the subject. Am I clear to you? Nothing can happen in one day. Gradually, we understand the topic, and gradually, our understanding for the subject improves. And the moment our understanding for the subject improves, we can do what? In a subject, we say miracles. But there is nothing called miracles in medical. We have applied a logical way, repetitive procedure, and we have divided the patient. For example, I have a trigger point over here, right? So as per rule, what do? You put a needle or you put a pressure or you do something to deliver the trigger point, right? What I do, I put a needle over here and then I see the trigger point is Radu. The trigger point is Radu. Radu means what? Right. You said gone. Trigger point is gone. No, Telugu. Or you know Telugu. Then how do you mean Radu?
नो सर आपका एक्सप्रेशन देख के पता
Yeah, teachers should have a very good expression. See, another phone call. I think your father-in-law is calling me. Hello? 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 Now you can understand how we understand the patient brainstem is affected. So cranial number 5, which supplies cranial trigeminal neuralgia, which works on facial work together, and corneal reflex. Such as cornea with a cotton and patient blood. So how we know? See, when a patient comes in a coma state, it is very difficult for us to understand. It is not your subject basically. It is a DM level subject. It is a subject of which level? DM.
DM level.
DM means what? DM means what?
Medicine of doctor.
No. Medicine of doctor is MD. Super specialization. It's a super specialization. It's the highest degree you obtain in medical science. It is called Doctor of Medicine. It's a specialized person who is trained on neurology. Right? He's an expert of it. You understood my opinion? So if you ask me whether the brainstem is affected, what I will do? I'll take one cotton and I'll pinch near the cornea. And then I'll check whether the patient blinks or if the patient is not blinking, means something is wrong with the brainstem. So whatever we see in the MRI, it has to be confirmed clinically. Right? Every time MRI is not correct, every time clinically, so it is always written in MRI. What is it is written? Please confirm it clinical. Am I right? Please go confirm. These are tests, they can have either, right? So confirm clinical. So all these symptoms will clinically justify whether the patient is having the relevant problem. And even after this, we cannot understand once there is anatomical damage, right? Anatomical damage does not mean that the patient will not. So MRI will not signify its improvement. The clinical investigation will justify its improvement every day. So when you do, this is often on the first day, but on the fifth day you see changes in these symptoms. So when you see the symptoms are changing, what do you understand? The patient is improved. Right. So cranial nerve investigation, generally the first semester. I always say one thing. So when you speak about facial nerve, we see about the smile, frown, surprise, and closure. So in facial palsy, facial nerve 7 is affected. Right? Bell's palsy. What is called? Bell's palsy. Which nerve is involved? Cranial nerve 7. So how do you understand he's having Bell's palsy? With 4 symptoms. What are they? Smile, frown, surprise, and close your eyes. So generally these people are not able to close the eyes. So generally we advise tear plus eye drop because if they are not able to close the eyes, they lose the vision. So whenever you see a facial palsy patient, you have to advise him on eye drop and you should recover this area as soon as possible. Generally I take 3 or 4 days to revive the facial palsy patient if there is no CNS deficit. Right? In 4 or 5 days, the case is over by 70%. You understood what I said? Yes. Now, for example, when we see facial palsy patient, we shall tell them show me your teeth. What you see? Like this. No, like a female patient, na? No. 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 Your wife also does in your room. This thing. लाला जी आपको आपकी वाइफ दिखाती है कि नहीं ऐसे?
हाँ सर ये तो कॉमन है
एक कॉमन है ना? तो ये समझ लो अगर पेशेंट ऐसे रोज दिखा तो परमानेंटली दिखा रहा तो बोल दो उसको बेस्ट पेल्सी है और बार बार दिखाती है तो बोल दो आपको मुंह का पैरालाइसिस हो जाएगा इसको बार बार नहीं दिखाना नर्व को स्ट्रेन करो उसको डरा के दो नहीं तो रोज दिखाएगी तो आप लोग क्या दिखाते हैं तो जब आपकी वाइफ ऐसे दिखाती है तो आप लोग क्या रिएक्ट करते हैं
कुछ नहीं सर कुछ भी रिएक्ट किया तो बड़ा रिएक्ट हो जाएगा भाई
पवार जी आप कैसे रिएक्ट करते हैं? आगे भाई जब मुंह दिखाते हैं तब क्या करते हैं?
सर हिला देने का सर, यस हाँ बोलने का बस।
माफ करो भगवान। हमें बोलते हैं माफ करो भगवान। उसने जमाना है था, वो आपके साथ पंगा नहीं लेने का।
नहीं हाँ, सही है सर।
ये तो सुबह की रोटी और शाम की रोटी दोनों नहीं मिलेगी। So NH stroke 4. Right? Facial palsy as quarantine encourage 0 minor paralysis, partial paralysis, and 3 is complete paralysis. Right? This is given a stroke of 4. Facial palsy is also having NIH score 4. 4 means 0 means normal, right? You are all in 0 score. Right? Minor paralysis, facial nosocomial score, asymmetry on smiling, like this. Right? 2. Partial paralysis, total on eyes will be wide open and total paralysis of the facial limb like this. The complete paralysis of both sides, upper and lower. So these are two parts, upper and lower. So in NIH score 3, you see the total breast palsy, the total area, even the eyebrow is not responding. It will not come up like this, right? Am I clear to all of you?
Yes sir.
Am I teaching in the right way or am I teaching in the wrong way?
It's okay, sir.
It's okay, no. This is the way. Right, sir. Facial palsy has to be gone with the scores, right? So now the brainstem. Now comes the cranial nerve 8. So you have feel dizziness. The cranial nerve 9. The glasiopharyngeal vagus. And now the most important part when you see ventilator. When you remove the ventilator and the patient is on tracheostomy, this is a very difficult stage. It's called dysphalancy. So we put the patient on the right. So these are the most difficult situations we face in the hospital because of aspirated pneumonia. The patient water goes in the lungs. The food particle goes in the lungs. The moment it goes in the lungs, what will happen? It is called aspirated pneumonia. Now the lung is not able to what?
Breathe.
Function. The lungs are not able to.
Function, sir.
So what we do immediately? We put him on higher antibiotics and we ventilate the patient. It is called mechanical ventilating. So this part, whenever you put a rice tube, you understand the patient is not able to swallow. So we have to teach him swallow therapy. Right? So brain stimulation is such a wonderful thing. It helps in each and every part of the improvement in the cranial. That is my specialization. Right? When I see such things are happening, it is my specialization that it helps in what? Each and every nerve investigation. Right? Achha, tomorrow and day after tomorrow I may not take the class. I am going to my teacher, right? Please mention in the group if someone is asking where it's in Tarang. Right? Where am I tomorrow? I am in Teams of Tarang. Maharashtra tomorrow. Where am I tomorrow? Maharashtra. Yeah. Teams Hospital, my parent institute, right? I'm with my teacher, I teach him. So cranial nerve 12. So this is the way we recover the paralysis. I'll teach you a wonderful way by which you can recover the voice aphasia. So when you work with what? Yes, that time also I told you have to work with facial nerve, uh, glosopharyngeal nerve, vagus nerve, and cranial nerve to this hypoglossal tongue. All these things when are very good. So when we investigate, we ask the person to put like this, close the cheek like this, like this. Can you see me? The ladies are doing like this. And Galaji, your wife also doing like this.
Yeah, sure.
तो वाइफ लोग का मूवमेंट से आपको सब कुछ सीखने को मिल जाएगा ट्रेनिंग ना 1 to 12 जब जीभ निकाल के ऐसे करती है ना तो बोलते कैरियर ना 12 जब यू करती है और कैरियर नंबर ओए आंख कैसे दिखाती है तो कैरियर नंबर 3 अब रोज उसको ऑब्जर्व करो और रोज उसको देखो आपको सारे कैरियर नंबर याद हो जाएंगे you know when the Chief Justice of Allahabad High Court was Chief Justice Chandrachud, Y.J. Chandrachud, and the Chief Justice of India was T.S. Thakur at that time. When Chief Justice of India visited the High Court, his Lordship was the Chief Justice who retired on 10th, right? So, his Lordship, when T.S. Thakur asked him, how did you remember the name of each of the judges? He just gave a clue. What? He kept all the albums of the judges, right? And every time when he was having a tea, he used to see this album with the name. So over a period of time, neuroplasticity took place and he remembered all the names of the judges. He was the only Chief Justice who knew every judge by name. Imagine Allahabad High Court has how many judges? 160. When his lordship, before being elevated as the judge of Chief Justice of India, T.S. Thakur was also the Chief Justice of the High Court. And then his lordship was amazed. How Mr. Chandrachud remembers all these names? Can you remember 160 names? No. But then I also tried the same way. I see your face every day, and now you come to my memory every day. After some time, I can remember that you were in the class, you were not in the class. That is why I say, please come with the what? Otherwise, how will I know you are there? So roll number 111 is there, see Gupta ji, Ramal Bikram Podi. अरे ये तो वो लगता है दोस्तों से रामड़ो अली अली रामड़ो. So this is the anterior blood supply, right? How from the blood, from the heart, this blood supplies to the different areas, right? Right carotid from the brain, right? So this is the right carotid artery, external carotid, right? Lateral carotid, left cells, subclavian vein. So what we do, we just go near the clavian vein, we give central line, right? When all the veins are left, we give clavian. What we do? Central line. So we use for the subclavian this for the what you call. What is this bone called? Central line is put in which this bone is called?
Sternum.
Sternum? No. Sternum is this one.
Clavicle.
Clavicle. Yeah. This called near the clavicle. They say when you go just go below the carotid artery, you will feel a pulse, and near the pulse you have the subclavian nerve.
No.
This vein, not one, vein, right? Through subclavian, there is a approach which we take, and central line is inserted, right? So when we insert the central line, when none of the nerve is responding. Yeah, veins are not available, not available. The veins are left. The patient is actually dehydrated. Now, if you see in my hands, will not get any vein because I have gone 5 times to ICU. they punctured so much in my hands and legs that it is very difficult for them to find a way. So every time I put on one. Central line. Whenever I put, yeah. In ICU, I'm always put on
Central line.
central line. Yeah.
Central line.
Yeah. It is called central line. So all this is not required so much for you. The anterior the circle of Willis is the place which will take another lesion, from which you can understand the different vascular blood supply inside the body. So it starts from vertebral artery, it goes to V, then basilar, from basilar, anterior, middle, and posterior. Then intercommunicating, then optical, then anterior communicating artery. How do you understand? V for vertebral, B for basilar, then posterior cerebral artery. The posterior cerebral artery goes up, then comes in the middle, is called the middle cerebral artery. From there, there is another junction, it's called optical vessel, right? It's a place in the optical area. Then goes the posterior cerebral artery. Then in the posterior node, anterior node, which is clear. And then which the area which is connecting the anterior is anterior communicating artery. So that area is called what? Circle of Willis.